When we think of Spain's healthcare system, we praise it, automatically thinking that it has one of the best systems in Europe. And that is true in many ways. It consistently ranks high in life expectancy and is known to have universal healthcare. However, universal does not mean equality. Today, we will be taking a deep dive into healthcare inequity in Spain, who it affects, why it exists, and what can be done about it.
When we say the term healthcare inequity, we refer to differences in access, quality of care, and health outcomes between different groups of people, with income, status, region, and gender heavily influencing health inequity. When discussing health inequity, cardiovascular disease is one of the prime examples as it is the number one leading cause of death in Spain. This includes strokes, heart attacks, and hypertension. According to the World Health Organization, cardiovascular diseases account for approximately 28% of all deaths in Spain, but these deaths are not evenly distributed across the population.
According to OECD, people in lower income households experience higher chances of a cardiovascular disease compared to those in wealthier regions. We see a commonality between a person's socioeconomic condition and their exposure to these risk factors. For example, lower income populations have less access to a healthy diet, which is vital for preventing cardiovascular disease. This creates a system where a nutritious diet is a privilege rather than a choice. Additionally, people in lower income regions require more physically demanding and unstable jobs, which ignores flexibility for health management, making it almost impossible. And finally, they also have less access to preventative screenings, which makes a cardiovascular disease develop over time and caught too late.
Geography further adds to health inequity. According to the European Observatory on Health Systems and Policies, rural areas in Spain have fewer healthcare providers and less access to preventative care. Without healthcare providers, access to care is limited. Without hospitals and clinics nearby, it makes preventative care nearly impossible, especially when taking into account that low-income homes are usually in rural areas. These homes do not have convenient access to transportations. This complex combination of variables leads to less healthcare for those who need it and an increase in cardiovascular deaths.
Why does this matter? Well, cardiovascular disease is very preventable. According to the World Health Organization, most cardiovascular deaths can be prevented through early detection, lifestyle changes, and consistent medical care. However, health inequity prevents equal access to prevention. This means that healthcare inequity leads directly to death.
To address CVD inequity, first, we must identify CVD early. This includes early screenings, managing modifiable risk factors, making screening accessible to all, and focusing on those in dire need. Ensuring that hospitals and providers can identify vulnerable populations and deliver care directly to disadvantaged communities, such as those who come from lower-income homes and live in rural areas. Lastly, integrated programs where primary care, hospitals, and social work have been proven to work, such as the case study from Poland, called Polish Managed Care in Acute Myocardial Infarction Program, show that heart attack patients entering a 12-month plan where intervention, rehabilitation, and follow-ups resulted in a reduction of CVD events by 40%, demonstrating that change is possible. Improvement doesn't always begin in large-scale actions or in institutions. It can start with individuals and communities. Those before have paved the way, so individuals can turn to organizations such as European Observatory on Health System and Policies and make a change. And if you want to learn more specifically about Spain's health inequity, you can visit Spain's Ministry of Health data and the book Towards Better Cardiovascular Health in Spain.